when Alice stands at the front. Good morning, everybody. I think we'll get started. Can you hear me okay? It's not usually a question I need to ask. You can usually hear me okay. Excellent, excellent. My name's Alice Straw, and as most of you in the room know, but we are, of course, joined by livecast this morning, so welcome. And I want to start off today with a land acknowledgement. I'd like to begin by acknowledging that the land on which we gather is the traditional territory of the Wendat, the Anishinaabe, Chippewa, Haudenosaunee, Métis, and the Mississaugas of the New Credit First Nation, and is now home to many diverse First Nations, Inuit, and Métis peoples. Today, this meeting place is still home to the many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So welcome to Cohort 15 Graduation Day. Yay! Now, I know the reason why you're really all here is you need to know what day it is today, right? How many of you looked it up so you thought you could get it before I told you? You were waiting for me. Thank you. It's nice to know I have a role, right? So today is the most important day of the year because it's Cohort 15 Graduation Day. Come on. But it's also, you'll love this, National Breadstick Day. Not sure what that means about lunch, Claire. Very interesting, it's National Frankenstein Day. I'm not sure that has any impact on your graduation speeches whatsoever. To recognize Mary Shelley, the author of Frankenstein. Interesting. Unrelated, it's also National Mincemeat Day, National Mule Day as the most underappreciated animal, National Pumpkin Day to get excited about Halloween, and National Tennessee Day because every state gets a day and today is Tennessee's. So there you go. You can rest easy because now you know what day it is. So let me just talk a little bit about some logistics before we get started. There is a white sheet in your package, I believe, that is a consent form, I believe. Is that true? Yes. You are all movie stars today. See, Laura's already flashing the camera. Those of you who haven't signed your consent, we'll just white you out of the photos. We'll just, Photoshop that. But that consent does allow us to use your photo today. And after each one of your presentations, you will also get your team photo done. So please sign those, because Laura is a great photographer, and you'll want your team picture. You will get a copy of it. I'll say a little bit more about the process for your presentations today, but I think we'll actually start our official program first. So I'm pleased to welcome Lee Fairclough. Lee is the Vice President of Quality Improvement for Health Quality Ontario, and Lee is here this morning both in her role with Health Quality Ontario, but also as a member of the Executive Oversight Committee with OPCN. So I'll turn it over to Lee.
For everything you've done to prepare to make this day special. Don't peek at that yet. But I do just want to say thank you. And as Alice mentioned, I'm here in two capacities. One is in my role at Health Quality Ontario with the privilege to work with the quality improvement team there. And as a contributing partner to IDEAS with IHPME and ICES and ourselves and all the medical schools. But I'm also here to speak on behalf of the executive oversight of the Ontario Palliative Care Network. And I'm going to talk a little bit more about some of that. When IDEAS was originally envisioned, it was with a clear recognition that if we wanted to have expectations that our health system could continually improve for patients, that we needed to consider that our healthcare team, those involved in providing that care, needed to be able to have the knowledge, skills, and the capacity to be able to approach improvement. We couldn't just expect it to magically happen. We actually had to provide some level of support to help them to do that. And we needed a team of people that were passionate about quality. Now that was easy because most people that are involved in delivery of care are pretty passionate about that already. But that we actually did need to prepare them and help them to manage the change and choose to make that care better. Now we're 6 years in. We've got thousands of people who have experienced the IDEAS program, either through the Advanced Learning Program or through the Foundations program. more people like you have taken the time for this advanced learning concepts. They've used it to improve access to mental health care, improve safety, decrease harm to patients, and many, many other areas. And here we are today, bringing together a group of people who care a lot about improving palliative care for patients and families in the province. But today is your day. It's a day to help us understand what you have learned about improving palliative end-of-life care, and I'm really looking forward to learning from all of you today. But beyond that, I hope that you will leave this program feeling a connection to a broader community in Ontario that care about quality and are working to make things better. Were any of you at Health Quality Transformation or the Quality Improvement in Patient Safety Forum last week, either in Toronto or up at the regional sites? Some of you were there. I really encourage you to get involved with this broader community. There's over 3,000 people who came together, and it's really, really clear that they draw an energy from each other. And we hope that you'll see yourself as part of that community as well. So how many of you feel like this today? Does anybody know who this group of ladies are? Whoop. Hold on. Anybody know who that group of ladies are? Soccer, good try. Good, better sport than that. Thank you, rugby team. So this is the 2016 Olympic bronze medal Canadian women's sevens rugby team. First time rugby was in the Olympics, Canadians went there and they got the bronze medal. It was pretty huge. Australia was very strong, they won. But you know, what was really incredible about this particular day was that that team had also previously in the pool play lost to Great Britain. They'd lost badly, actually. They kind of fell apart as a team. And then here they were facing them again for the medal round, and they won 33-10. So there's a certain inspiration, right, that comes from that. And you think about the work that you've been through the last little while. What does that look like? What has that felt like for all of you as a team? You know, you probably had moments at the top where you're like looking to pass off to somebody, and trusting that your teammate was going to be there to actually help you work through a set of barriers. How many of you feel like this? We really got to hit our aim statement that Alice helped me develop. I'm going to push through it. I know we can do it. But then what about the bottom? What's going on down there? What's going on in the bottom corner? Any thoughts? Any thoughts? So there, going straight ahead didn't work, actually. Something wasn't quite working. So they actually took a different route. They figured out another way through. And so, you know, you think, I love rugby, but when you think about any sport and you think about what we can learn from it and what we apply to our work in healthcare every day, it's the same kind of things. We set goals, we need to solve them as a team, and we need to find alternate ways to make things a little bit better and achieve what we'd like to. But yours is actually, what you've been working on and what you've been embarking on is much more, dare I say, as an athlete, I might get in a bit of trouble for this, but maybe just a little bit even more important. You're focused on making sure that things get better for patients, and you've really dedicated your time to it. And quality does matter. It really does matter in healthcare. And now you are actually contributing to making that happen. The Ontario Palliative Care Network. How many of you knew about the Ontario Palliative Care Network before you came into this program? That's great. That's a good sign. Many of you will know that the Ontario Palliative Care Network, I don't know why what am I doing wrong, Alice? I think I'll put my pen down. This is where I want to pass off. The Ontario Palliative Care Network, as you know, was really created to bring those that care about palliative care in the province together to look at how we can improve things. And you know, what do we know about care today? Well, we know this isn't the full picture, obviously, but we know a few things. We know that less than 60% of people who die in Ontario have a record of having received palliative care services during their final 12 months of life. We know that most people in Ontario still die in a hospital. This is higher than in other jurisdictions, though Always important to say, it has been something that has started to improve in the last few years. But also really importantly, we know that people, if they were to make a choice about their palliative and end-of-life care, that they might choose for something different than it being in hospital. And then we also know, actually, when we look at data around where people are receiving care in the home, we actually know that there's differences in access to that care based on features of equity. So those living in the poorest community actually are less likely to receive palliative-specific home care than those living in the wealthiest neighborhoods. These are just a few little things, but they're big things, right? They're things that we actually really care about, and I think have been the important part of grounding some of the work that you've been embarking on. Now, what is the OPCN? Oh, there's some pictures missing there, but that's all right. So really, the OPCN is an organized partnership of community stakeholders, health service providers, and health system planners responsible to develop a coordinated and standardized approach to how we might deliver palliative and life care in the province. Many of you will know it's been many years in the making to kind of have a formal strategy that we could focus on. And the network is really designed to bring us all together and help us move in the same direction. In that capacity, we're an advisor to government, that's a part of it. We're all accountable together. We want to look at the data that we have available to us. We want to, through the OPCN, we want to be able to support and source you to be able to do that well. And we want to look at some level of system coordination in the province. And then another key component of that is supporting implementation within the regions. So how many of you have been to or have been connected into your regional palliative care program? Lots of nodding, lots of hands going up. Fantastic, because I actually think part of the whole reason actually the OPCN made the decision to invest in ideas was so we could bring together those that cared about it and wanted to start to improve palliative care, and we're hoping that you can keep things motivated and moving within your regions. In terms of an action plan, there's an action plan for the OPCN where we laid out what we wanted to do over the course of the next few years. These are the themes. You can see some of them here about enhancing patient and caregiver engagement, aligning our planning. There's been substantial investments in hospice care the last few years, and that was a key influence and piece of advice that the OPCN provided for where they would be allocated to meet population need. We want to be able to enable early identification of people who would benefit from care. And we want to establish palliative care models that will actually increase access and enable adoption of the quality standards that HCO has put out, which means actually that people are going to be accessing more equitable care. We're identifying and connecting hospice palliative care providers and building competencies. And finally, very importantly to that, and hopefully you've gained an increased appreciation for this through the work through ideas, is that we're measuring and reporting on our progress. We've got a few measures that we want to actually use to see if we can actually move and ensure that we're making improvements in care. The first is that we want to be able to actually have data on the percentage of caregivers who receive palliative care services. And so we actually have prioritized expanding the use of the Caregiver Voices Survey across the province as part of that. The second is that we want to see an increase in the percentage of people who actually receive physician home visits and or palliative home care in their last 90 days of life. We've actually set a target that will increase by 5.8%. We want to see a decrease in the number of people who have had 1 or more ED visits or 2 or more ED visits in the last 30 days of life. And with the targets, again, that have been set with the LHINs, we're targeting to see a decrease of 4.8% or 4%. And then finally, we'd like to see the percentage of people who have died in hospital also decrease, and we've set a target of 5%. So you know now, having gone through ideas, what it will take to do that, the provincial level. Those numbers, 5% translates to a lot of people whose care we want to change and whose care we want to improve. I want to talk for just a second. This is actually work that Dr. Bob Sauls and the team have been leading at OPCN. They're on your panel here today, to establish palliative models of care that can increase access and enable adoption of quality standard that we've developed. There were some beautiful pictures here, so just picture what you'd like. Purple was patients and family caregivers, but this is really sort of outlining, why do we need a model of care? And, I think, again, when we think about the quality standard and what we're trying to aim for there, which is some level of consistency so that patients and families can know what they can expect, we also realize that we need to think about how are we going to function together as a team across sectors, across settings to deliver that care. And so we've highlighted already some of the inadequate and/or inequitable access that we see currently to high-quality palliative care. But on the provider side, we don't really have a roadmap to guide our health human resources in this area. And we don't really have a great mechanism to scale and spread some of the existing models that we have. And, really, there's limited and/or inequitable service capacity depending on where you are in the province. And so the framework is really meant to help us to solve that. And it really is, the work that's happening right now is to recommend a model of care that will deliver high quality, culturally safe palliative care in the province. And again, it has these 3 goals that map to some of the issues that I just described. Now, the first area that we're going to focus on really will be to put out this framework document. I was just talking to Bob this morning, and I think, we're tracking to have the final approval of that piece of work in January, and it'll be available to the field shortly after that. Your regional leaders, they'll all have a copy of it in its current form, so if any of you are particularly interested to do that, please do reach out to your clinical lead or your directors or your contacts in your LIN program to learn more about it. And, it will be looking at understanding how we're supporting patients best, depending on the complexity of their needs. And also considering in that model as well, what increased level of supports they may need. It's also designed to be able to address the quality standard as we've talked about before. Hopefully all of you are very familiar with that now, having gone through the program. Now, how does the work that you're doing contribute to this? So each of these had ideas on them, just to be clear. You'll see these titles on your agenda today. These are just a few of the examples of the projects you're leading today, that we're going to hear about today. There may be ideas that we need to kind of foster and spread to advance this action plan. So I wanted to come back to the action plan and just really highlight how relevant what you're doing is to it. That, we care about the early identification of individuals that would benefit from palliative care and long-term care homes. You'll see that written in the action plan. It's part of what we hope to improve. That the discharge pathway that's being developed for patients with advanced cancer and non-cancer illness. I like the title of that. That was a real intention of the OPCN, was to stop thinking about palliative care only for cancer patients or for patients with other illnesses. And then really, how are we thinking about the transitions between care settings? How can the model of care that Bob and the team have been engaging everyone in the development of across the system, how can it actually help us to improve the way patients and what patients and families can expect from their care? So this is just meant to map every single title on that agenda today. I couldn't fit them all. Every single title on that agenda maps to some part of this action plan. So after today, you will have a member of the OPCN team that is an ongoing regional liaison for you. We have a few of them here today. I'm wondering if you guys can just stand up and wave. They're over here. And, hopefully today you can get acquainted with who they are. Hopefully you already know them if you've been working in each of their areas. But really, please do connect in and stay connected with your regional palliative care leaders. We need to be able to share what you've done within your region. Certainly at HQO, we try to really spread all the ideas that you've got. We encourage you to post the outcome of your results on Quorum. And so please use that to inspire your colleagues more locally as well. So finally, just coming back to where we began. Today we're talking about palliative care. Today we're talking about OPCN. But now you're part of a broader community. Welcome to it. For those of you that quality improvement is newer for, there's many other familiar faces in the room. Thank you for all you've been doing to improve care. And welcome to our Ontario quality team. Hopefully we can help support each other and hope we can achieve improvements in care that we all would hope for. Thanks very much and have a great day and look forward to hearing. Did you want to do some questions?
Yeah, Lee, we got a couple of minutes for questions. Anybody have any questions for Lee?
And or for the OPCN more generally, I have other colleagues from the OPCN here that can field any questions.
It's okay to ask a question now. Just because you ask a question doesn't mean that we'll ask you a question when you're up here. It's okay. No? Yes, Angelica. Angelica, sorry.
Just, Lee, on your point about the health service delivery framework. So for those of you who don't know what that is, it's a multi-page document that Dr. Bob Sauls and originally Robin Cano led that describes the processes and structures for interdisciplinary community-based palliative care teams. Did I say that right? And to Lee's point, the document has gone out twice across the province, and it's already being used by actually some of you in the room to build palliative care teams in your communities. So we don't have to wait until March. The reason that we've got a March date there is because we have to translate it and make it AODA compliant and do all the fancy things, but it really is... it's in its near final form in the hands of many of your regional leaders, and our regional liaison staff can share that with you too. So if that's going to be helpful to you or your teams going forward, it's there for you to use now.
Great. Thanks, Angelica.
Thank you.
Anything else? Okay, let's get
Well,
down to
I know
the main
Lee's here
topic.
for the morning. Thank you for that information. And Lee's here to enjoy your presentations. So please seek her out at the break as well if you have any questions. Thank you to Lee. Okay. So now I got to be the logistical person here. By the way, the other day it is today is the day that you change from being IDEA's participants to being IDEA's alumni. And thanks to Lee for mentioning that. And there's a whole new world of opportunities for you as alumni. And sorry, but Agnes and Joe and Shauna and I will be on you about all your alumni learning, and it doesn't stop today. So welcome to the alumni world. I guess you actually officially join the alumni world when your presentation ends. So if you feel some sort of, crowning or something that happens, that's why, because you've just transitioned to alumni. That's fantastic. Logistical stuff. We have heard from a couple of people that they're having some challenges with the live cast. We know that it's working on this end. If where they're watching blocks YouTube, that's what the challenge is. So what we would suggest is that if they have the ability to tether or something that can bypass their firewalls, but it is definitely working. We've checked in with a few folks where it is working, and it seems to be a YouTube block. So if you're not allowed to watch all those funny wonky donkey videos at lunch, you're probably also not going to be able to watch the live cast today. So, but maybe they can get around it by tethering to a different Wi-Fi. But also know that today is being recorded, so that if it's your mom or your dad or your kids who are having trouble getting in, you'll be able to show them the recording of your brilliant presentation and the entire proceedings from today. So you will get that link, and that will not involve firewalls, of course, because it'll be a recorded video. So at the very least, we'll look after you that way. Just speaking of the live cast for a moment, we do need to be true to the microphones today. Although we may be able to hear you in the room without a microphone, the folks that are watching us can't. So we'll have folks running with the microphones as we have during your learning sessions, but we will ask you to wait for your questions and comments until the microphone is there. Otherwise, you'll just look like a talking head with no words coming out on the video. So if you can indulge us in that, and we'll make Joe and whoever else is running microphones get their steps in today for sure. Let's talk about flow. This is a quality improvement learning opportunity, so we have a flow map for how the graduation presentations will go. So according to the agenda, you will know where you are. You will come up here to the front, and we'll ask you to come up on this side. All this matters. We'll ask you to come up on this side. Your poster will appear up on the screen, but as you know, that's just visual for people to look at. You are telling us the story of your QI journey for the last 5 months. This microphone, as you know, works very well. You do not have to be extremely close to it. But if it seems like we're not hearing you, you may see my hand come up and move it a little bit. Don't let me frighten you, but just to make sure that you're being heard really well. Claire is our timer today, the lovely Claire. And Claire, you are going to sit where, do you suppose? Right there, probably? So you have to make eye contact with Claire. Today is not the day that you can ignore Claire, okay? Because Claire is your timer. And so as you know, you have 10 minutes. She's going to give you a 5-minute warning. She is going to give you a 1-minute warning. And then she's going to give you a stop. When Claire says stop, I will start to come up onto the stage. I'm the hook, and we need you to stop. After your presentation, we will hear from our panelists, and I'm really pleased to welcome our panelists here today. So our panelists are Susan Blacker. Susan, you want to stand up? Susan Blacker, who's the provincial co-lead for the Ontario Palliative Care Network. Thank you. Angelica Golnell, who's the director of the Ontario Palliative Care Network. Thank you, Angelica, for being here. And Dr. Bob Sauls, one of our clinical system navigators, also the clinical lead for Health Services Delivery Framework for the Ontario Palliative Care Network. So they're here today as your panel. They are curious about your projects and curious about why you did some things, maybe what something else that you might have thought of. It is not a knowledge test. They are not your pass or fail people. They are here to spark your learning and spark your interest. And after your presentation, we'll ask them if they have any comments or questions. If we still have time, then we're glad to take comments and questions from you as well. Just remembering we do need to use the microphone. We will time that part as well because we do need to stay on agenda for our folks who are, for your mums and dads who are watching us at home today. We want to stay on time for them. What else do I need to remember to tell you before we start? Talked about microphones, talked about 5, 4, 3, 2, 1. On your table there are green papers, one for each of you. Throughout the day we ask you to use those papers to reflect on your personal ahas. This is information that that OPCN is collecting and will help to inform their ability to think about how your work and quality improvement has impacted your palliative care work, give them some feedback of things to think about, some information for the regional liaisons around what was your big learning, what were your big ahas around this. It is individual. It is, there are no names on it, so you can say whatever you like on those. And we ask you, once you've completed it, just fold them in half and leave them on the table, and we will collect those at the end of the day today. Hopefully you've all signed your consent forms. And one last thing before I'm turning it over to the first group.
Alice, so you asked them to come in from the right, but then you got to tell them to go.
I'm going there.
All right, sorry. I will wait patiently for that information. I will no longer interrupt you.
We'll make sure we take the batteries out of Joe's microphone. So yes, after your presentation is done, panelists will ask you some questions of curiosity, make some comments, then we'll ask you to go off to this side. On this side, the reason why Joe's concerned about this, Joe will hand you your certificates. And the lovely Laura, who is our newly found photographer, will take your picture over on this side. As you're getting your picture done, here's the flow part of it, I'll ask the next group to come up and be ready at the podium. And that's how we'll keep ourselves on time and on task today, okay? So the flow goes this way, all right? Excellent. And before, one last thing is also to remind you that along with your ahas and all the things you're going to hear today and all the thinking that you've been doing leading up to today, remember that we're in our change day period of the year at Health Quality Ontario. The official Change Day is November 22nd, and Change Day is a couple of month-long process where you have the ability to pledge to make a personal commitment to changing something in your work. And you may hear some things today that will spark some Change Day pledges for you. We're already at, I just checked this morning, 2,060 pledges across the province, which is phenomenal. So ask you to keep Change Day in mind today as well. You can go online, make your personal pledge. You can pledge anonymously. You can join somebody else's pledge. But as you're hearing information today and you're thinking about, some additional changes you want to make, Change Day is a perfect place to document those commitments because we know that what's documented is done, right? So think about that as we go through today, and I'll remind you again at the end. And so now it's 9:30. And what 9:30 means is that we are going to hear from our first presentation. So improving goals of care discussions in long-term care homes. Hero, Carrie, Bella, Joanna, and Linda. Give them a big hand because they're going first. Can I steal this chair? Thank you.
Good morning, and thank you for joining us this morning. We're excited to be the first group to share our project. My name is Carrie Burley, and I'm the social worker for Mackenzie Health Long-Term Care. With me, I have Bella Grunfeld, the nurse practitioner at Mackenzie Health, and Hiro Nakajima, Quality Improvement Coordinator at Valley View Residence. Unfortunately, Joanna Walker, the clinical manager from Valley View Residence, could not join us today. We would like to thank our executive sponsors, as well as our management teams at Mackenzie Health Long-Term Care, and at Valley View Residence. The title of our project is Improving Goals of Care Discussions in Long-Term Care. We wanted to focus on this area because currently on admission, it has been observed by both of our homes that the resident, family, and substitute decision maker are not always fully aware of their loved one's medical condition and prognosis. And we tend not to discuss end-of-life wishes. As a result, advanced care planning and resident wishes are not clearly stated or discussed between the family, resident, and interdisciplinary team. Oftentimes, the family is not educated and prepared by the interdisciplinary team regarding their loved one's health condition and options for care. When there is an acute change in condition and decline in functional status, the family feels overwhelmed and are not aware of the healthcare choices available to their loved one. Many times, appropriate healthcare can be provided in the long-term care home setting. Families tend to make decisions under stress with the best intentions in mind, but unfortunately, this often results in avoidable transfers to the emergency department. In some cases, the resident will die in the ED or in the hospital setting, which may not have been his or her choice. Our goal with this project is to bring to light the need to have meaningful and frequent discussions regarding goals of care for our residents. When our team embarked on the Ideas Project journey, we knew we wanted to have an impact on avoidable ED transfers. However, we noticed that to have those meaningful goals of care discussions, we needed to address several other factors that could be improved upon. These include areas that are highlighted in our driver diagram. We used the fishbone diagram for diagnostic purposes, and it helped us to determine that we could improve consistency and timeliness in identifying residents at the end of life. We could increase physician involvement in goals of care discussions and improve resident and decision-maker awareness with regards to goals of care and end-of-life choices. Our theory is that consistent, timely, and documented goals of care discussions with residents and their families will help improve the quality of care provided in the long-term care homes and will enable us to provide the right care at the right time, in the right place, by the right provider. As we were developing our Big Dot and project aims, we determined that our project will focus on enhancing informed decision-making for the residents and their families, and resident choice in place of death, which would ultimately impact end-of-life care, and in turn would decrease avoidable transfers to the ED. Our further discussions led to the project aim statement that residents who are at the end of their lives will have their advanced care plan and goals of care identified, documented, and reviewed regularly in both of our homes. It also led us to our Big Dot aim, which was to decrease avoidable palliative care resident transfers to hospital. We conducted a number of PDSA cycles during our project. We tested the use of the palliative performance scale on one unit of the home to determine if and what PPS score will help us to identify who are nearing the end stage of life. After PDSA cycles, we determined that a 40% PPS score was helpful in identifying those residents who were nearing the end of life. In order to complete a more comprehensive assessment, we applied the gold standard framework for those residents whose PPS score was 40% or lower. As a result of the PDSA cycles, we also found that the GSF was helpful in guiding evidence-based goals of care discussions with residents and their families, and to identify end-of-life wishes. We used PDSA cycles to test the change idea of arranging a special care conference with the family for those residents who were determined to be at a significant risk of decline and would benefit from a goals of care discussion with the team. The goals of care were discussed and documented in the electronic chart. We also included residents on the same unit who had a regular care conference already scheduled in order to discuss and review their goals of care with the team. We utilized the same tools such as the PPS and the GSF. As we discuss our data, it's important to note that our baseline data began at 0. We started at 0 because at the beginning of our project, none of the residents in each home had their goals of care discussed and documented consistently using the PPS and GSF. At Mackenzie House Long-Term Care, we used one unit of 58 residents. The PPS was completed for each resident in July, August, and September. We noted the residents who had a PPS score of 40% or lower. Special care conferences were scheduled and goals of care were discussed and documented. Our data showed an improvement due to an increase in the number of goals of care discussions documented. In July, there were 6, August, we had 5, and in September, 4, with an overall total of 15 goals of care discussions documented over the 3 months. Some of the predictions we made is that as we progressed with our project, there would be an increase in goals of care discussions leading over time to a better implementation of palliative care, an increase in the quality of care provided with a greater emphasis on pain and symptom management, and an overall decrease in avoidable ED transfers.
And I will be talking about some of our challenges and next steps. So some of our project biggest challenges surrounded workload and electronic medical record. We considered the possible barrier in buy-in by the nursing staff. We were concerned that the nursing staff would receive additional tasks added to their workload. However, as the project continued, we observed that our project's approach was accepted by the staff because the processes we used aligned with the existing processes in the home. The staff perceived the new tools to be valuable to their roles rather than adding to their workload. Ultimately, as a result of this additional communication by the team to the families and decision makers, they provided qualitative feedback that they felt supported and well-informed at the end of life. We also found some challenges with regard to electronic medical record in the homes. We wanted to have access to the palliative performance scale through the EMR. However, this is not currently possible because of a number of reasons, including EMR diversity in 2 homes. The diversity of EMR systems also creates inconsistency in how long-term care could document PPS scores and goals of care. Now a little bit about our next steps. Our project's next steps focus on home and LIN levels. On the home level, using the driver diagram as a reference, we'll continue to implement our process to other units in both homes. This would include identifying palliative champions, implementing palliative education regarding pain and symptom management, and consistent use of tools. At the LIN level, we will share the results of the project with the Central LIN Palliative Care Working Group, as well as at the LIN engagement with the long-term care home sessions that are planned in November. We will share the results with nurse-led outreach and hospice palliative care teams to better support our homes. Our overall goal is to continue to share and disseminate best practices for palliative care delivery and long-term care, and to ultimately improve quality of care for all the residents. In conclusion, our advice to those who begin on QI journey is to remember that quality improvement is like building a house. You must lay down strong foundation that is grounded in QI processes and principles, such as using your QI tools, use your PDSA cycles, and measuring the effects of change ideas. And remember that the key to success is strong supportive team, leading by example, patience, and perseverance. It's a journey that does not end. It's an ongoing process, hard work, and it's rewarding because the improvements we make, they will positively affect all the residents in the homes that we support. So it's a great feeling of satisfaction. And I'd like to thank all the members of the IDEAS team and Health Quality Ontario for giving us this great opportunity to learn more about quality improvement and how to use the skills to better serve our residents and to provide best palliative quality and high-value care to our residents. Thank you.
Thank you. That's a beautiful summary, thank you. And this set the gold standard there exactly on time. Okay. I'm shocked that workload in the EMR were a challenge for you as well. I'm sure no one in the room can relate to that. Panelists, what are you curious about?
Well, actually, this is very interesting because it aligns exactly with some of the things we've called out in long-term care with the framework. You've addressed some of my questions around barriers around workload and the EMR, which I had flagged right away, and that's an interesting question because I think it's an important one. One of the questions I have is, how did you engage physicians around this work? Where did they fit into this?
So we approach
Talk to
this.
them. Yeah, you just need to call.
We approach this topic on one level and also during our professional meetings that we have quarterly, PAC meetings. And the way we talked about that, we talked in general about palliative care and having those discussions, and people do find it very challenging and intimidating because everybody would like to talk about how we would make improvements and things would get better and people would get better, but telling the families and the residents that they're not going to get better, that's hard. You know, humanly it's hard. So the way we talked about that, we said, well, it's a hard topic to approach. However, look at those tools. They help you to have those discussions. They give you a little bit of structure. They help the families and residents to see that this is not something that is your opinion, but there are certain other evidence that exists in their condition that helps you to make certain prediction. And it's not about doing something for the team, but it's more something to do for the residents. It's more resident-centered. And they felt that was a valuable tool because it makes their work somewhat more manageable.
I want to applaud you and thank you for thinking about ways to improve palliative care delivery and goals of care conversation in long-term care. You've touched on...
Susan, can you go a little closer to the mic?
A little closer?
Yeah.
Okay.
Maybe bend it down a bit, Mike.
You've touched on so many of the opportunities not only to empower the residents around articulating their values and wishes and what they might like to have happen, acknowledging the distress that family members feel when they step into that substitute decision maker role, but also how it feels for the teams to be caring for residents at the end of life when some of these things just aren't clear. So I just think this is a lovely example of how a very focused initiative can have that ripple effect for all of the key folks. My question is, it sounds like it's felt pretty successful. How will you decide where you go next in the homes? Are you finding a bit of a culture shift where other teams or other floors are saying, hey, when are we next? Or are you going to have some real championing that you're needing to do on a next team? And how will you engage those involved in this pilot to help do that? You need to sort of expand your quality team now.
So some of the aspects of our project in our long-term care home, we already are doing some of those things. So what we've done with this project is just work towards enhancing what we're already doing and also formalizing what we're doing. So we're looking at using tools, not just and we also do have, nursing assessment skills and the physician assessment skills there in play to say where a resident might be clinically. But this we're hopeful that this will help us identify those residents even sooner. Using specific tools and hopefully working towards a formalized program description for the home. We do have our policies, but we want to be able to say we do this, this, and this, and it's very transferable to all of the units in the home.
Any other comments or questions? Lee has one.
What was the response of the team that you were working with as you moved to sort of introduce this, or the suggestion of introducing the PPS, et cetera?
Everyone in the team was open to what we were proposing. I think it brought to light the need for an increased capacity for all of our staff on all levels. It also brings to light the need for even our physicians to work towards having that discussion a little bit better. So I think it's just sort of pushed us to go further. And I think it was quite accepted by the team because then we had a way to really talk about what we're doing and why, and how it really did bring the team together.
And it was also helpful that the processes in our ideas projects were aligned already with the processes in a home. So whenever possible, we avoided creating new tasks, but rather utilize and capitalize on those things that are already in place, like scheduling the conferences and using certain tools that perhaps some of the staff were more familiar with.
Excellent, thank you. And this is kind of the alumni transition. It happens somewhere in here as you go down to that side of the stage. Thank you. I can be alumni, I'm not alumni. I can be alumni, I'm not alumni. So as these folks receive their certificates from Shauna and get their photo taken, we'll call up our second group, Identification and Communication of Key Client Information and Goals for Palliative Clients. Natalie, Tanya, Linda, David, and Leanne. And we'll just give these guys a chance to get their photo done, and then we'll be good to go. Don't your posters look great up there? It's pretty exciting, eh? They look really cool.
We have to say hi to Peterborough. Yeah.
Shauna, don't. Excellent. Take it away.
Thank you for having us. We're representative of the Central East Lynn in the form of Tanya and Leanne, and David, Natalie, and myself, Linda, are from Hospice Peterborough. Hello to our audience at Hospice Peterborough. Our poster is called Fish on Fridays. Our project is called the Identification and Communication of Key Client Information and Goals for Palliative Clients. We wanted to focus on this project because we felt that the medical model often directs the end-of-life care. Our experience working with people who are dying has allowed us to appreciate the benefits of a broader, holistic journey as identified by the HQO and OPCN palliative care standards. Initially, we focused on identifying and communicating goals to the broader circle of care, our theory being that clients who had a broader perspective of care had a better experience. This led to our aim statement, palliative care clients of the Central East Lynn will have their care needs and preferences captured and clearly shared and known among the circle of care. In order to understand more about our project, we used the following diagnostic tools, as painful as they were: driver diagrams, process maps, and experimental knowledge mapping with the PCN and HQO standards. We are indebted to Agnes, who couldn't be here today, but who was our coach in our diagnostic journey and found the following tools to be the most helpful: the driver diagram and the process map. Based on the diagnostics we completed, our understanding of the baseline data, we decided to adjust our target population by changing the PPS to 50% and expanding the caseload to all palliative care clients in the Peterborough region. Our test of change resulted in the creation of a goal sheet. And I know we all moan when we think, oh no, yet another tool we have to use. But it's very fluid, it's very quick to use, and it really doesn't take any more time given what we're already doing. Our data showed, so when we looked at our data, it showed that there was a data spike shortly after learning event number 2, surprise, surprise, because we came back, we were charged up, we were energetic, we went out there and we completed goal sheets like crazy. But this didn't get sustained, and we believe that the reasons for the dip were there were fewer referrals, of which we don't have a lot of control over. We all had holidays because it was in prime summertime, and there were some unexpected deaths of clients. So clients that after one visit we thought we'd be able to work on goals, and lo and behold, they died when we hadn't planned that they would. We continue to recognize the need to collect data, and that will be one of our goals in the future, that we're going to continue our data collection. Our next steps will be promote the understanding of goals as a tool to increase client-centered care and planning, to coach and support clients and families to achieve their goals. Sometimes the journey towards the goal is what's really important, and it's not actually achieving the goal, it's just that you can talk about those goals outside of the medical model. To improve communication among care providers using communication templates, coordinated care plans, and care conferences. And we have a lot of exciting ideas about how we can leverage opportunities for informal and formal care conferencing. Engaging other members of the care team to assist clients in non-medical goal setting, and to continually evaluate, refine, and improve the processes. We need to validate that goal setting is value-added, a value-added component of our interactions with clients. We think it's value-added. Is it important to clients? And we need to continually validate that. Our biggest challenges in this project were working across 2 very different organizations, but I must say working with the LHIN has helped us to understand and appreciate, and if anything, it's strengthened our bond. I think we had a strong bond to begin with, but this project has really helped us strengthen that bond, and it's been a great experience. And also, we also have other stakeholders and a variety of other organizations that we have to work with, and other community members. So we're continually working on strengthening those bonds and getting them engaged in this non-medical client goal setting project. Palliative clients are not, the other thing that we learned is that palliative clients are not predictable. As we work through with patients on goal setting, patients would sometimes die before their goals were stated or met. And we also had to remember that our focus is the client, and for some of our clients, their goal is the journey, and that's as good as we get. Our advice for anyone starting on a quality assurance journey is starting in the summer is difficult. Given that referrals are often lower in the summer, and people do things like take holidays and have vacation. The principles and information gathered in this project are applicable to many other areas of your work and organizational projects. And often that's what we do. When we were having our weekly meetings, we'd get caught on tangents and say, hey, we could do a PDS for this, or we could do a map for that. And I think that will improve overall the work within our organizations. But we have to remember that sometimes we have to rein back and keep focused on the project at hand. We also recommend that people utilize the expertise of their coach. As we said, Agnes was invaluable, and we really found it very helpful, particularly with that little tricky thing called QI macros. Speaking of which, QI macros, don't let it intimidate you. It certainly didn't intimidate Natalie. She was a real trooper on this, and we just let her go with it. We found it was very helpful to have one group lead the QI macros and to work more closely with our advisor to get that right. Group participation is extremely fortunate, and I think we structured it so that we really did have interactive pretty much weekly throughout the last 5 months of sessions. I mean, there were a few times when we didn't meet, like Thanksgiving, we decided, hey, we don't really need to meet today. But we really did do a great job of getting together. And as I said, it was this weekly touch base that was really important. It kept us on track, it kept us together, and it kept us cohesive. We were also surprised and pleased that at Learning Session 2, a lot of the projects are really aligned. And I know when I heard the first group speaking this morning, I thought, geez, I could just stand up and say ditto. The projects are a little different, but I think the whole gist of this whole experience has been people are out there trying to improve care for clients. It's not about the organizations that are delivering the care, it's about the client experience. And we're all working towards making that a very positive experience. We are all going to die. It's the journey that's important, and we all have a role in helping people recognize that it can be the best thing possible.
Thank you. And thank you for your honesty. You know, no pain, no gain, I'll say, but sometimes it's a little bit painful, so thank you for your honesty. What are you curious about, panel?
Well, one thing I just have to call out that you said that really struck a chord was the issue of the relationships among yourselves. Because sometimes we get very focused on the work and don't actually spend the time to develop the relationships. And I think I've learned over time that that actually is crucial besides QI macros. The other question I had was, or the question I had was, how did you share the goals of care with the broader team involved in the care of the resident or client?
Yeah, so after the second learning session, we actually created a bit of a goal sheet, which was a very basic goal sheet. So not to kind of compete with the health links, which is much longer and much more, I guess, in depth. This was literally the goal, the person who wrote the goal down with a bit of check boxes on the bottom to say, I have shared this from my end with the care coordinator, with the family physician, and with the nurse practitioner, and then to send that off simply to the care coordinator, Leanne, or whoever got that, to let them know we have shared it with this person, this person, and this person. Whether that it was fax mainly most of the time because we didn't have access to any form of common EMR, which is an ongoing issue. So to kind of keep it simple, we let them know who we shared it with, what the goal was, and who was working towards that goal.
Thank you and congratulations. This is really great work. You should be very proud. My question is, I think, building on what Bob alluded to, which was, and I also struck a chord with me, was when you talked about working across multiple organizations. And if you can just maybe talk a bit about what you thought some of the key success factors were. What made that successful? Was it in-person meetings? Was it someone I talked to this morning talked about co-locating? What do you think some of those success factors were in building those relationships?
Okay, we're really, really, really lucky in Peterborough that we have really strong palliative relationships already across all the participants in Circle of Care. So it's much easier for us to facilitate projects like this because we're already meeting with one another regularly. We're already sharing information regularly. So it's just an enhancement of what we already do. We have one palliative nursing agency contracted through the LHIN. So we also have a tighter base that we're working from, which we realize is not necessarily the same across the province, but our big thing is encourage those relationships and just keep talking to people.
I think in addition to that, it's important to recognize the palliative doctors in Peterborough. They are a very tight group, and we work very closely with them all the time. We see them weekly. We talk to them daily, and it's a really, really good relationship.
I was just going to note that I think so many in the room and in other care settings can relate to the challenge of not being able to have those fulsome goals of care conversations because a patient's condition changes and declines too quickly. And so I just was thinking how even that challenge illuminates other opportunities for the broader palliative care network to be championing early identification and moving some of that important work further upstream. And how neat would it be if there were more details provided in the referrals that are coming to you around goals of care. So, embrace those tough challenges as a network. And I just have to say, I'm so touched by how you titled your presentation. I see the little note on the poster about the fish and chips on Fridays goal. I think the residents of Peterborough are so lucky to have all of you engaged in this work.
So let me just refer for a moment to that, because that was our very first official goal piece, although we've been doing it a lot. So Leanne from the Lynn and I went to visit this wonderful dear client of ours who, up until recently, she had been able to drive her and several of her colleagues in a long-term care facility, or pardon me, in a seniors facility to go for lunch on Friday for fish, which was their outing. And when we talked to her about what life was like for her now, since she had lost her driver's license and nobody else drove, she said, I just miss having fish on Friday. So we said, what if we can make a way for that to happen? And that was our very first one, and she loved it.
What about Johnny, though, so they don't think she's sickly sweet?
Your time is up. I'm sorry. You become alumni now. Stay all day. But please seek this group out over the break and hear that Fish on Friday story is fantastic. Thank you. So as they become alumni, I want to call up our next group, which is Discharge Pathway for Patients with Advanced Cancer and Non-Cancer Illnesses. So we should have Christine, Cindy, Julie, and Megan. Excellent. Come on up and get ready.
Okay, so you can see everybody. Hello, everyone.
Oh, hold on just a sec.
Yeah, wait just a second.
Sean has to do her photobomb.
Oh.
Very nice. Way you go. Thank you.
Hi. So my name is Megan, and I'm a care coordinator with the palliative care team at the Southeast Local Health Integration Network, Home and Community Care. And our team was made up of two large organizations. So we have team members from Kingston Health Sciences Center, specifically Kingston General Hospital, which I will refer to as KHSC from here on in because it's a bit of a mouthful. So unfortunately, our team lead, Dr. Christine Knott, couldn't be here today. But with me, I do have Cindy Bolton, who is the Director of Community Partnerships with KHSC, and Julie Heaney, who's the manager of the palliative care program at the Southeast Lynn Home and Community Care. So our project was called Discharge Pathway for Patients with Advanced Cancer and Non-Cancer Illnesses. We wanted to focus on this project because recent interviews with patients and caregivers coping with advanced illness, along with shared experiences from physicians, clinicians, patient experience advisors, and home care coordinators describe transitions from hospital to home that didn't always go well. For example, delays in discharge date from hospital, delays in receiving services, supplies, or equipment in the home. When we started, we hoped to have the following impact on patients, and specifically those identified as benefiting from a palliative care approach. We wanted to improve the patient and caregiver experience and transfer process when being discharged from hospital to home with home and community care services. We wanted a continuation of care supports. Our theory was that a process for early identification and intervention was already in place at KHSC, so we were lucky to have that already there. The process was to screen and identify patients who would benefit from a palliative care approach specific to palliative care pathways for COPD, congestive heart failure, chronic kidney disease, and metastatic cancer of the breast, lung, pancreas, and colon. This screening process was also identifying within those flagged patients those who were at greater risk for discharge, meaning that the patient was at greater risk for rehospitalization and needed supports and care in place for the transfer home. And so the question became, how can we better ensure a safe discharge with uninterrupted care between hospital and home, including the required supplies and equipment? That led to our AIM statement, which is, by October 2018, 50% of patients identified as requiring palliative care during a KHSC admission and also determined to require continued palliative home care supports will receive a customized, coordinated, and assured discharge plan and handover. And that was the word we really liked, was the handover. So in order to understand more about our project, we used the following diagnostic tools. And this was really helpful for us. We started by mapping the admission, referral, discharge process from both the hospital and the community perspectives. This was very important because we all assumed that we had an understanding of what each other's processes were, when in fact we didn't. There were some surprises on both sides, and it showed areas where delays may occur and potential areas for tests of change. We definitely had a few light bulb moments there. Next, we used the process mapping to develop a fishbone diagram, and from there our driver diagram started to take shape. From all of these tools, the importance of timing was highlighted and reinforced what patients and caregivers were saying and what clinicians had described to us. We then completed a chart audit on patients that were screened and flagged from winter 2018 as benefiting from a palliative care approach, and also identified as a higher risk for rehospitalization post-discharge. This allowed us to again look at factors specific to time intervals, communication of information, and communication with patients and their caregivers. This audit provided information on specific areas where small tests of change were possible, with quick payoffs that weren't too resource intense, and also some measurements we might use. So our diagnostic findings, or our aha moments, included that the patients we were seeing in this chart audit were actually younger seniors. The median was 66 years of age. The median hospital length of stay was about 6 days, so you've potentially got some time there to get ahead of the ball. The majority of patients were in common at the time of admission to hospital. In other words, they were active with home care services when they were admitted, but none of the patients were on a palliative care caseload at home and community care. So this means that at the most recent assessment prior to hospitalization, patients' needs were designated as acute, rehabilitation, maintenance, or just longer-term care. Caseload assignment was often short stay, which means that no home visit by a care coordinator was required. We also noted that the patient's SRC code, the service recipient code, did not change post-discharge, so there was no change in the designated level of needs from the time they were admitted to the time they were discharged. Did you want to add a little comment about, we did speak with some care navigators about some of our observations.
So we just found it really interesting that the chart audit actually confirmed the observations that our care navigators had. So right now we have care navigators on each of our medicine teams. And so we had a focus group with them just to try to understand from their perspective what they felt the biggest challenges were in the discharge for these patients. And they identified that the patients who are at end of life actually get very good discharge planning if they are in fact able to go home, but it was the patients that they saw as actually changing rapidly while in hospital. So a PPS of 60 or 50, between 50 and 60% and 30% were the ones that they were seeing that were the ones that they felt that we really needed to put some shared attention on to actually have a better discharge process. So it actually was interesting to see how the audit confirmed that.
Mm-hmm. Yeah, definitely. And so even though that process was in place to assess those palliative care needs, the process was not yet in place to communicate that information on the referral. So the referrals that we received didn't have information related to that discharge risk that was identified or the palliative care needs. So there's an opportunity. 90% of the referrals didn't request a face-to-face CC assessment, a care coordinator assessment, which meant that a telephone assessment would be completed instead, not necessarily prior to discharge. Delays were noted related to repeated unsuccessful attempts to reach a patient by phone. The median was about 2 days from discharge to the first nursing home visit and about 2 or 3 days to the first PSW visit. So based on the diagnostics we completed and our understanding of the baseline data, we identified 3 potential tests of change, all of which are process-focused. So test of change number 1 is early identification. We want to introduce an early call and information exchange by a KHSC clinical designate to the patient's Southeast Lynn Home Community Care Coordinator. That's someone they're already assigned to. Test of change number 2 involves effective communication. And that introduces the KHSC clinical designate as the navigator or coordinator of that patient's discharge and initiator of that fulsome, timely LIN referral that we're hoping for. Test of change number 3 is this key seamless transition, the process for face-to-face home and community care coordinator assessment in consultation and collaboration with the KHSC clinical designate to improve and ensure a timely, customized, and coordinated discharge plan for that transfer from hospital to home. So we did run into some challenges over the course of our project. An IDEAS project doesn't exist in isolation. Ours was influenced by a number of factors. KHSC and the Southeast Lynn Home and Community Care are in the midst of some real transformational change, both individually and together. Leads, champions, and key project individuals moved to new roles during the project. Processes are also changing at the same time, most notably a transition from paper home and community care referral to e-referral, right in the middle of the project. Projects that cross organizational boundaries require due diligence and agreements for data sharing that meet privacy legislation. These take time, and this did take a lot of time, but we feel that the time taken to review the baseline data has offered important insights and a strong foundation for continuing work, and I liked someone earlier mentioned that foundation. Due to these factors affecting the IDEAS project, we were unfortunately unable to actually conduct any of our tests of change at this time, and I feel like we're just getting started now at this point. The ball is finally rolling, and we will continue on with this. So our next steps will be to try these tests of change, even if we're simply simulating the first test of change during all of this organizational flux. Planning is underway for both a simulated test for our early identification, that test of change number 1, as well as plans for all the tests once our enablers are in place. So we really want to thank our organizational executive sponsors and Agnes Gibson, who couldn't be here today, for her consultation as we moved through all of these challenges. Also, we would like to thank Dr. Deborah Dudgeon as acting as our HQO IDEAS palliative care and scientific expert. And finally, we would like to thank the Southeast Regional Palliative Care Network for selecting our proposal and our team to participate in IDEAS and allowing us to work together.
Thank you. I am shocked to learn the world doesn't stop spinning just because you're in IDEAS.
Imagine.
Wow. It's a big aha for me this morning. Panel, what are you curious about? And folks in the audience, please, we find what happens is as more teams have done their presentations, we get more questions from the audience, right? So don't be afraid. We won't pick on you if you haven't gone yet, but think about what your questions are. I'll defer to the panel first, though.
I particularly appreciated when you talked about the aha moment of using the process mapping and realizing nobody quite saw this the same way. Will you continue to use that kind of tool?
Yeah, I think we were just discussing this at a meeting the other day, and as far as how exactly to develop these tests of change more fulsomely, using the process mapping procedure to actually know, okay, what are we looking at? Where exactly can we develop these tests of change? How will this work from everybody's perspective?
One of the interesting things we saw in the process mapping, as Megan has said, the hospital side mapped their process, and then the community home care side mapped their process, but all of our data was from our patient's process, and they don't see the difference. So we were trying to figure out shove those two processes together to figure out what the patient was going through. So that was a very critical point when we saw, there's very big gaps in time and delay and lack of communication. So hopefully at the end of this, the process map will look a little smoother for all people involved.
This really struck me because I spent most of my career sitting in the middle of these transitions. And I guess maybe the question I have is what are your thoughts about creating the relationships between the hospital community and the out-of-hospital community? I mean, you've described some of the technical things to do. How do you create the human relationships to do this effectively?
We are very fortunate right now that part of that flux that we were referring to was a large change in the medical directorship of KHSC, and including the palliative care and the Queen's Palliative Medicine. And the goal of the new person coming in is to create that very much more of a fluid, ignore the borders of what is hospital and what is community, and figure out how we work together better. So we are well underway. That's part of what we're doing right now, is many, many different meetings of how can we work together. And we keep raising that very point of the patients don't see you as different, so we need to stop seeing ourselves as different as well and all own the process. So that's part of what we're waiting for, is all of that work to happen, and then we can start our project again.
I mean, I think you've picked a very important issue that exists not just in your region, but across the whole province. So I congratulate you on identifying that.
Thank you.
Excellent, yeah. Angelica?
Thank you and congratulations. I think this is really important work, and I'm glad to hear that you're going to continue it, because I think there's a lot that we would like to learn provincially, but also others across the province would like to learn from you as you continue. Maybe you've thought about this, and because I can't read your poster, I can't tell, but my eyesight's not that good. Just wondering if you've thought about measures, indicators that you would collect, maybe in a dream world, maybe in a real world, to measure your success and what those might be.
Yes, we have thought about that. One of the, as we're just getting started, right, things change as you go through and you'll identify different things. One of the measures that we didn't have up here that we have talked about but haven't gotten to yet, because we haven't started yet down that road, would be understanding that patient satisfaction and that caregiver satisfaction. And part of that, what we talked about, was surveying their understanding of what their plan of care is as they go home. So that was one of the sort of big gaps in all those process maps of hospital had this information, home care had this information, but nobody had actually told the patient. So understanding so we'd have to survey the patients basically for that to see if their satisfaction improves. We do have the baseline survey of that's what they were saying, and one of the other things that came out of that original survey was their indication that they felt like they had to do it. So they were feeling like care coordinators themselves. They had to follow up. They had to find out. They didn't know who to call. And so it would be following up with another survey and seeing if their satisfaction improved, if their understanding improved.
If their perception of the time. It's one thing for us to measure, this is the time the referral was sent, this is the time the referral was received, but what's the actual patient perception of how long that whole process took, right? Regardless of what we say it is.
And we'll now graduate you to alumni. And as these folks receive their certificates and get their photo taken, we'll welcome up Whitewater Bromley CHC, Brenda, Margaret, Heather, and Lara, and I believe Stephanie and Katie are watching us, hopefully. Just want to mention too, around the posters, these posters will all be posted to the project section on Quorum on Monday. So if you're seeing things up here that you're interested in, by all means, and I believe they are currently on campus as well. So those of you who have access with your mobile devices today, these posters are all sitting on campus if you wanted to have a look at them. Excellent. We'll give these guys a moment. Away we go.
Okay. Thank you. I'm Brenda Powers-Ross. I'm the director of Whitewater Bromley, and our team consists of Margaret Cleash, she's an RN, Heather Robertson, nurse practitioner, Lara Miley, health promoter. We have Stephanie Knox, who at the last minute was unable to come with us. She's a care coordinator with Home and Community Support, so she's joining us by live stream. Hi out there, Stephanie. And Dr. Katie Forfar, our ad hoc committee, was Dr. Katie Forfar, who is one of our physicians, and the Renfrew County Community Paramedics. So I would like to say thank you to the dedication of the team, because on top of a busy schedule, we structured weekly meetings and they were very consistent. So we were actually approached in 2017 by the Champlain LHIN. They were looking for people of interest that were looking to improve their palliative care project. And interestingly enough, we had just internally had done a survey and had some client feedback and provider feedback, and that we realized we needed to work on our processes and systems. We felt that there was, the results of the surveys demonstrated that there was a lack of standard processes and systems. The evidence that the providers felt that there was different levels of comfort because different levels of experience dealing with palliative care. and that the providers' feedback was that they felt there was too many crises, so we needed to do something to address those. So with that, we signed up at Cohort 15 with the goal to improve this with an approach to, through early identification, we would increase the quality of life and symptom management for clients with life-limiting illnesses. So when we began the project, we had hoped our impact, and this was the next three things, we hoped that we would ensure clients and families would have an improved palliative approach and end-of-life care, that by adapting and disseminating educational resources, that we would build capacity among our primary care providers, and that the utilization of the expertise of our external services, home and community care, and the Renfrew County community paramedics, that we would avoid unnecessary visits to the ER, and that, because that's obviously not the most appropriate place for a palliative care client to be seen. So with having Stephanie at the table and the Renfrew County paramedics, we spent a lot of time learning about what were the external resources out there, where could the gaps be filled, how could we capitalize on that expertise. So our theory was that palliative care clients and families would have a better experience in the end of life and would benefit from a standard approach with early identification. So when it came to our aim statement, somebody talked about being painful. That was being 100% of clients identified as palliative using the surprise question, or would you benefit from a palliative care approach? We would have a completed palliative care flow sheet by today. So to assist us in our project, we utilized the tools such as the staff survey I mentioned, client feedback, run charts, PDSAs, flow charts, and the driver diagram. And I think out of that, we decided that the most helpful was the driver diagram. I can't talk about that today, I don't know why. PDSA and the P-chart. So based on our diagnostics and our understanding of the baseline data, we realized we needed data from a longer span of time due to our low numbers. Like, keep in mind, we had 2 providers piloting this, and in a small community health center, thank goodness, our palliative care numbers weren't high. Or people that we felt that would meet that criteria. So stage 2 will be by incorporating the other providers within the center. Obviously, we'll have a larger number to work with. Our test of change resulted in the incorporation of the surprise question as part of the client visit. So we did a lot of discussion as providers that are really busy in their day. How do, they've got so many things to remember in that client visit. How are they going to remember that surprise question and how to start initiating the process? So we actually incorporated that right into the EMR template so that it was like a flag, I guess you'd say? Yeah, like a reminder flag. So the data collection had been limited, like I said, but we did establish a baseline for the surprise question, and the percentage of patients asked the surprise question is about 10%. And the percentage of patients who were no for the surprise question was about 64%, and this appeared stable. And that was we had to do a shout out to Laura, how do we do this? So that's how we came up with that. Our next steps is to continue to collect data, review and critique our protocol for improvement, and that would be more so as our number get higher and as we continue to pilot it. To incorporate the PPS tool for assessment after the surprise question results in no. We want to, and we've actually got some of these booked, educate all the staff, including even the admin, in LEAP, advanced care planning, and any other relevant education, so that everybody in the community health center can talk the same talk, and even at different levels of expertise, everybody will have an understanding that's to their level. And a caregiver survey to be completed initially and within 6 months. So our challenges, time commitment. We knew it would take a lot of time. I think we had hoped that even by allowing the time, things would move faster. So consistency in adapting the change. We realized that the QI team really had a lack of knowledge for the external services, and that's why it was so valuable to have Stephanie, the home and community support, and the community paramedics sitting at the table. It was a slow test of change because of the low numbers. And we predict the spread may be difficult because we know change can be difficult. So when we start to spread that amongst the other providers. But we are grateful that the two that are piloting are feeling the pains, so we hope that we have a lot of those things smoothed out. Frustrations, as we sometimes felt that we should be moving along a lot faster. Our advice was continue to connect with your QI advisor. Alice was very dedicated, can't see her right now. Allow yourself the time. Make sure you block off that time. So what we did, and we continue to, because we realize we have spent the last 9 months, but we're just getting, I think, to a point where we feel that maybe we can start moving forward. So we have continued. Our project certainly doesn't end today. It's still blocked off, and the weekly meetings will continue until we feel that we are at a place that we can be. Be prepared, do some research. Having the right people at the table, at your QI table, is very important, and we were, like I said many times, fortunate that we have such a diverse team. Everybody comes with a different aspect. We realize, too, that our advice is that maybe you do need the external expertise to maximize improvement and to find the humor.
Thank you. You know, for us as your advisors, when we hear you say we're on the verge of something, that gives us a little flutter. Like, that's what we love to hear. So thank you for that. What are you curious about, panel? And folks, be thinking of your questions of curiosity or your comments as well.
I just have, so did I understand you correctly that when you used the surprise question, you had 64%, is that what you said? 64% were no, I wouldn't be surprised?
Yes.
Am I correct?
Yes.
Once that, screen positive, in other words, what were the next steps, or what are the next steps?
The next steps, and maybe Heather can help with this too, but the next steps we feel would be to initiate, to get an idea of where those people are at first. So by incorporating the PPS scores, by making referrals early to the LIN, by talking with families about advanced care planning, setting everything in place. So it's not a crisis, it doesn't get to a crisis point where families are really, really stressed, don't know what's coming next. we feel the line of communication should be always open, always transparent, and incorporating all the services.
Yeah. The other thing too, which part of that early identification was establishing and developing a palliative care flow sheet in the chart. So we are in a bit of transition because our computer system is changing. We did, and this is the part of, a lot of us didn't even know this flow sheet existed in our current EMR, okay? And that we had a lot of discussion around that in terms of, some of us didn't feel it was appropriate, didn't capture all the data we needed. Anyway, but that is a work in progress. But that flow sheet is something that we started to use, and it's a good communication tool because as providers, a lot of us are there part-time different days, so if my peer is away and I need to go into that person's chart to get a quick picture of where they're at in their palliative care journey, it would help give us that information. And then also, I think the goal is that we can use those flow sheets when we do external referrals. And again, part of that early identification was getting referrals in early to home and community care. Because we did learn, even though we know, they have lots of experience in palliative care and are willing and are there to help these patients. And I think as providers, we weren't doing that soon enough. So getting them identified early, getting the referral in early. Yeah, so, does that make sense? Yep.
Yeah, that's great.
Go ahead. Fight over the microphone.
Thank you. This is great work. I guess a question for you. I think you're fortunate in that you are working in a CHC environment, and thinking about this kind of an initiative in a non-CHC primary care environment. If you think about what you've learned so far, what might some of your advice be to other primary care environments that might not have sort of the existing, it's a hard question, I know. And if you don't have any advice, that's okay, but I'm thinking, how do we do this in other primary care environments? It's gonna be a lot harder.
I guess I think we were fortunate because most of us were in-house, and then we only had the two extra, I guess trying to develop those relationships early is key. And we're still doing that, in our CHC with some of our external providers.
It's the relationship building piece.
And it's then making a commitment to dedicating the time, I think, is key, right? Because it's so easy for everybody to be so busy, but dedicating time, making it a priority, obviously, is number one, and then making connections early with people, inviting them to the table, and then making a dedicated effort and time to hammer it out.
I think that's what I would have predicted. I think that's probably it, yeah.
Yeah, anybody?
Excellent. So as you transition over to alumni, thank you. And so that brings us to our break. And so over break, my challenge to all of you is think about the questions that you're going to ask the groups that are coming up after break. Some of you are now relieved of your presentation anxiety today, so we would like a little more discussion from you. But we will come back right at quarter two with our Northwest folks. So please network with each other, seek out others you want to ask questions of, and we'll see you back at 11:15.